Good day and welcome, guys. Today we're going to be having a full lecture on abnormal uterine bleeding, known as AUB. We're going to be using the outline, introduction slash definition, incidents, classification slash types, clinical features, investigation, treatment, and summary. So the term dysfunctional uterine bleeding was specifically used when genital tract bleeding was not associated with any genital tract abnormalities, general or endocrinological diseases. In this case, hormonal imbalance is considered the root cause of hyperplasia of the endometrium that causes menorrhagia. This often happens in anovulatory cycles with excessive or unopposed influence of estrogen on the endometrium. So here, the term dysfunctional uterine bleeding was specifically used to genital tract bleeding that was not associated with any genital tract abnormalities, whether it was general or endocrinological diseases. But in this case, hormonal imbalance is considered the major cause of increase in the number of cells of the endometrium that would further result into excessive bleeding. This often happens in cycles that ovulation do not occur, therefore resulting into excessive and unopposed action of estrogen on the endometrium, which is the inner layer of the uterus or womb. So several causes may be attributed to abnormal uterine bleeding in an individual, whereas none may be detected in some. In some, the lesion detected may not be the real cause of abnormal uterine bleeding. So you may discover a lesion in some individuals with abnormal uterine bleeding, but it might not even be that lesion that will be the cause of that abnormal uterine bleeding. So Figo in 2011 came forward with a new nomenclature of abnormal uterine bleeding instead of dysfunctional uterine bleeding. Also a new classification system to define its cause. So this classification is named Palm-Cohen system. P is for polyp, A is for adenomyosis, L is for leiomyoma, M is for malignancy, C for coagulopathy, O for ovulatory dysfunction, E for endometrium, I for iatrogenic, and N for non-classified. About 10 to 15% of women experience episodes of abnormal uterine bleeding at some time during reproductive years of their lives. It is common during the extremes of reproductive life, following pregnancy, and during lactation. It has been shown that 55.7% of adolescents experience abnormal menstrual bleeding in the first year or so after the onset of menarche. Menarche is the first menstrual bleeding. So, what's the pathogenesis of AUB? Endometrium normally produces prostaglandins. Prostaglandin E2 and prostaglandin I2 are vasodilators and antiplatelet aggregates. Prostaglandin F2A and thromboxane A2 causes vasoconstriction and platelet aggregates. Progesterone is responsible for secretion of prostaglandin F2A. The absence of progesterone and thereby of prostaglandin F2A causes menorrhagia. Tissue plasminogen activator may be increased, thereby causing menorrhagia as well. Endothelium may be lacking or low when there is abnormal menstruation. So here, the endometrium normally produces prostaglandins, prostaglandin E2 and prostaglandin I2. So prostaglandin F2 and thromboxane A2, which causes vasoconstriction and platelet aggregation, which will decrease blood loss. Now, progesterone is the basic hormone that is responsible for what? Secretion of this hormone PGF2A, that's prostaglandin F2A. So the The absence of progesterone now will result into the absence of this hormone prostaglandin F2A, which will result into abnormal bleeding. On the other hand, tissue plasminogen activator may also be increased as a cause of this pathology going on, thereby causing abnormal bleeding as well. And so endothelin, which helps the body in preventing excessive bleeding, may be lacking or low when there is abnormal menstruation, resulting into more blood loss. So what are the classifications slash types of AUB? Abnormal uterine bleeding is of two types: anovulatory cycles, that's 80%, ovulatory cycles, that's 20%. It is classified as abnormal uterine bleeding in reproductive age, abnormal uterine bleeding in childbearing age, and premenopausal women. So we'll be looking at abnormal uterine bleeding in the reproductive age. Abnormal uterine bleeding has replaced the term dysfunctional uterine bleeding as discussed in the earlier slides in a woman of reproductive age in the absence of pregnancy. Abnormal uterine bleeding may be acute or chronic. Acute bleeding may occur sporadically de novo or may be superimposed on chronic abnormal uterine bleeding and requires immediate treatment. Chronic abnormal uterine bleeding is described as abnormal menstrual bleeding that lasts for 6 months or minimum of 3 months and requires thorough investigation. Abnormal uterine bleeding does not include the bleeding caused by lesions in the lower genital tract. So in case you have a wound in the vagina and is resulting into bleeding, it is not an abnormal uterine bleeding. So there is a new classification system to define its cause by FIGO 2011, Palm Cohen classification. One, we have polypus, that's AUBP. It is categorized and defined by ultrasound, saline sonography, hysteroscopy with or without histopathology. P category is subdivided according to number, size, location, and histology. We have adenomyosis, which is AUBA. It is diagnosed by ultrasound and MRI scan. We have leiomyoma, which is AUBL. Many leiomyomas are coincidental findings and are not the cause of AUB. In majority of cases, you see multiple leiomyomas. 4 is malignancy and premalignant lesions, that's AUBM. This group is rare in the reproductive age but may occur in women with polycystic ovarian disease and chronic anovulation. 5th, which is coagulopathy and is AUBC. It consists of a spectrum of systemic disorders of hemostasis that can cause abnormal uterine bleeding in around 13 to 20% of women of reproductive age. 6th is ovulatory disorders, AUBO. 80% are anovulatory cycles with unpredictable, irregular menstrual cycles, some with heavy bleeding. 20% are ovulatory but may be a consequence of luteal phase defects, events with deficient progesterone. So 7th is endometrial causes, that's AUBE. See the pathogenesis rarely may be due to endometrial TB, that's endometrial tuberculosis. 8th is iatrogenic AUB, that's AUBI. This may be caused by steroidal hormones administered as contraceptives, especially in low dose, that's an intrauterine contraceptive device. Copper T may cause unscheduled breakthrough bleeding or menorrhagia. Anticoagulants, phenothiazine and tricyclic Antidepressants, which affects dopamine metabolism, may also have a role to play in abnormal uterine bleeding. Ninth is not classified as AUBN. Rare causes not well defined or diagnosed are atriovenous malformations, varicose veins of the uterine vessels, myohyperplasia, that's increase in the number of cells of the myometrium of the uterus. In others, no cause is discernible by existing investigations. So, abnormal uterine bleeding in childbearing age and premenopausal women. The menstrual cycles are painless as most cases are anovulatory cycles. Endometrial studies are important in premenopausal women to rule out endometrial carcinoma. We'll look at metropathia hemorrhagica. It is a specialized form of anovulatory abnormal uterine bleeding seen in women between 40 and 45 years. It is not related to parity, so it's not related to the number of childbirths. The symptoms are typical. The woman develops continuous painless vaginal bleeding, sometimes starting at the onset of menses or preceded by 6 to 8 weeks of amenorrhea. Occasionally, the woman reveals a history of menorrhagia prior to this. The uterus is slightly bulky. This condition may stimulate abortion and ectopic pregnancy if amenorrhea precedes bleeding, but pain is conspicuously absent. So, this is the diagram of a metropathia hemorrhagica. Here is the cross section of the uterus showing thickened myometrium. So, what are the clinical features? A history of the onset, duration, and amount of bleeding should be noted. Antecedental causes such as intrauterine contraceptive device, pills, pregnancy, abortion, drug therapy are also pertinent in these cases. General examination with special reference to anemia. So, in your general examination, you should also have it in mind that an abnormal uterine bleeding is loss of blood, which would certainly result into an anemic condition. Pelvic examination should be done in case there is a lesion in the pelvic cavity which is resulting into the bleeding. So what are the investigations to be done? You do a complete hemogram, which is also known as full blood count. You do the bleeding time and clotting time. You check the thyroid profile as indicated. You do pelvic sonography or sonosalpinography. You do diagnostic hysteroscopy. You do diagnostic laparoscopy. You do endometrial study by ultrasound and curettage. You do sonosalpinography, which can delineate a submucous fibroid clearly. You do pelvic angiography, which is required when the cause of menorrhagia is not detected by other means. This shows varicosity and atriovenous fistula. What is the treatment of abnormal uterine bleeding? The treatment should be based on the age of the woman, her desire to retain fertility, previous treatment, and severity of menorrhagia. Treatment could be general or specific. Specific treatment involves conservative, which is medical, and conservative surgery such as myomectomy, which is the surgical removal of uterine fibroids. You can also do radical hysterectomy, also known as V times hysterectomy. There is a video on indications for V times hysterectomy. You can watch it and understand it better. So, what are the general treatments? Anemia should be treated simultaneously. First line of treatment is medical therapy. That's you give blood tonics. Then secondly, if that fails, you think of blood transfusion, which will be indicated. So what is the conservative treatment? That's expectant management. If the menorrhagia is not heavy and the woman is not anemic, menstrual charts for a few months should be observed. Spontaneous cure is possible and can be awaited. Anemia can be treated appropriately if it exists. So combined oral contraceptives, that's 20 to 30 micrograms EE plus progesterone 4 cycles in a year. Progesterone 5 to 10 milligram tablets 10 to 30 milligram daily for 3 weeks cyclically, continuous 3 monthly or 3 monthly injections or implants. You give gestrinone 2.5 milligrams twice weekly. You give danazole 100 to 200 milligrams daily. You give gonadotropin releasing hormone analogs 4 weekly injections. You give tranexamic acid 1 gram 6 hourly. You give non-steroidal anti-inflammatory drugs such as mefenamic acid 500 milligrams 3 times daily. You give etamisilate 500 milligrams 4 times daily. You give Myrinema intrauterine contraceptive device 52 milligram levonorgestrel. Omilosiphin 60 milligrams twice weekly. So let's look at the summary of medical management. Medical treatment should be the first line of treatment unless contraindicated. The drawbacks are the side effects of the hormones and the fact that symptoms are sometimes returned once the hormone therapy is stopped. Prolonged therapy may not be desirable. If medical therapy fails or is contraindicated, consider Mirena intrauterine contraceptive device. If Mirena fails or side effects develop, go for ablative techniques. Second generation ablative techniques are safer, quick to perform, and equally effective. When the above methods fail, consider hysterectomy. So minimal or conservative surgical methods of treating menorrhagia as the ablative technique. There is first generation, here hysteroscopic ablation, endometrium resectoscope, rollerball laser, that's TCRE. We have the second generation, here radiofrequency, induced thermal ablation, balloon therapy, microwave ablation. Also have uterine tamponade in acute bleeding. There is bilateral uterine artery embolization to prevent bleeding. So what are the contraindications to conservative surgical treatment? If uterine size is greater than 12 weeks, that's 12 cm, volume greater than 30 milliliters. If there is uterine fibroid, scattered uterus, that's previous surgery. Young woman desirous of pregnancy, that's if the woman is young and desires to get pregnant. Adenomyosis, that's TCRE, can cause dysmenorrhea. Genital infection, that's a genital tract infection. Uterine cancer or pre-invasive cancer, or there is an atypical hyperplasia. So we'll move to hysterectomy. Hysterectomy for abnormal uterine bleeding is required if medical methods fail or menorrhagia recurs. In older women more than 40 years not desirous of childbearing and who opt for hysterectomy as a primary treatment or ablation fails. Laparoscopic hysterectomy or laparoscopic assisted vaginal hysterectomy, that's LAVH, can be done. Vaginal hysterectomy for uterine prolapse. Vaginal hysterectomy is contraindicated if uterus is grossly enlarged, previous surgery with possible adhesions, fixity and limitations of uterine mobility, presence of endometriosis or adnexal mass, nulliparous woman or women with a very narrow vagina. Note also that in a woman less than 50 years, ovaries should be conserved unless they are diseased. So what are the new system? VasaPoint bipolar electrosurgical system works in normal saline, is cheap, has excellent hemostasis and causes instantaneous tissue vaporization. Thanks for listening.